Good evening, everyone. My name is Marie Gertz and I am Professor and Head of the Department of Nursing at the University of Melbourne. It is my great pleasure to welcome you all to the University of Melbourne and to the 2021 Marian Barrett Lecture. Before we begin though, our formal proceedings, just a couple of words of housekeeping. You have been automatically muted and your camera is deactivated. We invite those watching to propose questions in the Q&A box at the bottom of the screen, and I thank Professor Denise Harrison for moderating these questions. Please note we will not be using the raise your hand function. A recording of the webinar will be circulated along with some key resources following this webinar. We will also be sending you a survey to rate your thoughts on tonight's events. So we look forward to hearing your thoughts, good and bad, all the ways we can improve. I want to now first though, humbly acknowledge the traditional custodians of the land on which I am working this evening, the Wurundjeri people of the Kulin Nation, recognising their enduring connections to the land, water and community. I pay respect to Wurundjeri elders past, present and emerging, along with all our First Nations people who might be present with us online. A warm welcome also to members of the Barrett family, our students, alumni and our colleagues, and to Professor Louise Harms, Deputy Head of the Melbourne School of Health Sciences, and of course to our speaker this evening, Professor Sanchia Aranda. Sanchia, as an esteemed colleague, we are so delighted you've come back to the University of Melbourne in this, the 25th year of nursing at Melbourne. Today, International Nurses Day, I would also like to pay tribute to our profession. The catastrophic impact of the COVID-19 pandemic shines a light on the true public value of nurses and nursing. Since February 2020, each and every day and from all corners of the globe, media have captured in real time the immense suffering of critically ill people requiring our expert care. If nurses have in the past been invisible, what the COVID-19 pandemic has clearly shown us is the essential nature of our work, the work nurses do 24 hours a day, 7 days a week, caring for the sick and saving lives. Here at the University of Melbourne, we are so proud of what we have achieved in just 25 years. We are especially grateful to our partnering health services, our alumni and our school community as we work together in research, evidence-based practice and educating the next generation of nurses. I now call upon Ms. Isabella Bolotto, President of the Melbourne University Nursing Student Society, who will provide us with a brief history of the Marian Barrett Lecture, and then to Professor Harms to introduce the 2021 Marian Barrett Lecture. Thank you, Bella.
Thank you, Marie, and good evening and welcome all. As the representative of the Melbourne University Nursing Student Society, it's a pleasure to introduce the Department of Nursing's prestigious Marian Barrett Lecture and celebrate 25 years of nursing at the university. James Barrett was born in Melbourne, the son of a medical practitioner and a former matron of the Women's Hospital in Melbourne. After graduating from the medical school of this university, he practiced in England. He returned to the University of Melbourne as a lecturer in ophthalmology and the special senses. A member of the University of Melbourne's Governing Council for 45 years, he held positions as Vice-Chancellor, Inaugural Deputy Chancellor and Chancellor. Barrett was committed to the promotion of national health and believed unequivocally that educated nurses were pivotal to good health, and particularly that of women and babies. In the 1920s, whilst visiting universities in America and Canada, he became convinced of the merits of tertiary education in nursing and campaigned to create a similar pathway at the University of Melbourne. While unsuccessful during his lifetime, Barrett left £750 towards the founding of a school of nursing via the Marian Barrett bequest. The spirit of James Barrett's bequest was revived with the foundation of the School of Postgraduate Nursing at the University of Melbourne. The inaugural Marian Barrett Lecture was delivered in 1997. In her own right, Marian Barrett was an accomplished artist. She studied at the National Gallery's School of Fine Art in Melbourne and Marian painted all her life. She maintained a studio in Collins Street and donated many of her works to good causes, including the Victorian Bush Nursing Association, of which her husband was honorary secretary. Aged in her 70s, she again became a student, tutored by Arnold Shaw at the Bell Shaw School of Art in Melbourne. Marian and James Barrett were married in 1888 and had 5 children. We are confident their descendants will be proud of the Department of Nursing's 2021 Marian Barrett Lecture. Without further ado, I would now like to hand over to Professor Louise Harms to introduce our speaker.
Thank you, Marie and Bella, and welcome all. Well, it is indeed a great honour to introduce this year's Marian Barrett Lecture and our speaker for tonight, Professor Sanchia Aranda. As many of you know, Professor Aranda has worked in cancer and palliative care settings since 1979, predominantly in research and teaching roles then between 1989 and 2010. Her research interests centre on the development of an evidence base to enhance supportive care outcomes for people affected by cancer. She's conducted several randomised control trials of novel nursing and supportive care interventions. Professor Aranda now leads a multidisciplinary research group based at the Peter MacCallum Cancer Centre here in Melbourne, where she also has a joint appointment with our Department of Nursing. She's received in excess of $2 million in competitive research funding for her work. And she's also leading a national project under Cancer Australia to develop a framework and curriculum materials to support the development of cancer nursing and the cancer nursing workforce in particular. Professor Aranda, in amongst all of that, is of course a successful graduate research student supervisor, to date having supervised 11 doctoral and 9 Masters by Research students. Since 2010, Professor Aranda has worked outside the academic sector, first as Director of Cancer Services and Deputy CEO of the New South Wales Cancer Institute, and most recently, until 2020, as CEO of the Cancer Council Australia. Professor Aranda is a past president of the International Society of Nurses in Cancer Care, a past president of the Union for International Cancer Control, and inaugural board chair, City Cancer Challenge Foundation. So it's now my great pleasure to invite Professor Sanchia Aranda to deliver the 2021 Marian Barrett Lecture. And her presentation is entitled, as you can see there, Can Nurses Reduce the Health Impacts of Inequity, Leading from the Front Line? So handing over to you, Sanchia, and welcome to this lecture tonight.
Thank you, Louise, and good evening, everyone. I would also like to begin by acknowledging the traditional owners of the lands where I am today, the Kulin people, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and emerging. And I would also like to acknowledge that I do that in the context of a discussion on inequalities within the Australian health system. And although that is not the focus, Aboriginal and Torres Strait Islander outcomes are not the focus of my presentation, it would be remiss not to acknowledge that inequity in health outcomes is most deeply experienced by our First Nations peoples. It's an honour for me to deliver the Marian Barrett Lecture this year and to be part of celebrating 25 years of nursing at Melbourne University. I've been 24 years part of that team, coming as one of the first staff members when Judy Parker moved across from La Trobe, where I had worked with her. So it's a real pleasure to be here tonight. To put my presentation in context tonight, I want you to imagine the world of a woman called Maria. She's fictitious, but is an amalgamation of a lot of people that I've worked with over my 40 years. Maria's a 40-year-old single mum. She lives in rental accommodation in an outer city suburb. She works the equivalent of full-time, but in a range of casual employment roles that allow her to juggle the care of her daughters. She collaborates with a neighbour who's in a similar situation to her, and together they achieve their caring responsibilities and manage to bring a sufficient income to keep their families in a reasonable state of well-being. The children's dad lives in another state and has little to do with the family, and Maria's relatives live overseas. And more recently, her mother has had a stroke, and she's helping support the costs of care for her elderly mother, who's being looked after by her sister. And if you can just hold on to Maria's world for a moment as I go through some of this presentation. So first, some definitions. And the first of these is to distinguish between equality and equity. So equality refers to the degree to which all persons are treated as indistinguishable from everyone else. So thus we treat them all identically and grant them the same quantity of a good per capita. So in the illustration on the left, you can see that there are 3 boxes, 3 people, each person gets a box, but some people can't see, I'm sorry, the American baseball game. I haven't worked out how to make that cricket or AFL. Equity, on the other hand, is to understand or answer the question of how fairly and socially just are the resources distributed throughout the population. And that has 2 guiding principles, one being equal resources for equal need, and the second being higher resources for higher need. And so you see on the right-hand side of that illustration that to give everybody the same outlook on life, one person needs 2 boxes and another person needs none. It's important when we think about this to consider the topic of tonight in the context of the social determinants of health. These have been defined by the World Health Organization as the conditions in which people are born, grow, live, work and age, and that includes the health system. These circumstances are shaped by the distribution of money, power and resources at global, national and local levels. And the social determinants of health are mostly responsible for health inequities, or the unfair and avoidable differences in health status seen within and between countries for the WHO, but for the presentation tonight, also between groups in a population. And I'll be using cancer as an illustration tonight, and it's important in that context to understand that of the 15 countries with like health systems that participate in international cancer benchmarking, Australia is number 1 in 5 of the 6 benchmarked cancers. And you'll see that that is a mask for how things really look. These social determinants of health are often understood through indicators of educational attainment, income, or level of occupation. And Australia indeed reports on some of this data. So in Australia in 2019, 65% of people in the adult age range held a non-school qualification at Certificate 3 or above. And that had increased by 17 percentage points in 2004. And for any of you who've been watching the debate on female equity in Australia recently, women in Australia have the highest educational attainment of all countries in the OECD. And so all of the inequalities in things like income and position, superannuation gain all occur after they've finished their non-school qualifications. In addition, about 10% of the population live in low-income households at the point of 2017-18, and this is defined as less than half the median equivalised household income. It'd be interesting to see what COVID-19's done to that statistic. Amongst major occupational groups, managers had the highest weekly average total cash earnings in 2018 at $2,425 on average a week, while sales workers had the lowest at $736. The other indicators are that 1 in 10 Australians report having low social support, and 1 in 4 or 25% experience some degree of social exclusion. That rises to 52% among those with chronic long-term health conditions, and it's even higher still for people with a disability. And this is an area I've become increasingly interested in and through my involvement with Scope Australia. When we look at some of these in the way the IHW look at the impact on health, you can see that compared with people in the highest socioeconomic group, people in the lowest group are more likely to smoke, they're more likely to have diabetes, they're also more likely to be obese, which is probably related, more likely to state that that cost is a barrier to seeing a dental professional and a barrier to fulfilling a prescription. And so we know that people in these lower socioeconomic groups may in fact compromise their medical treatment and care for a disease like cancer because of the sorts of things that, such as costs for filling prescriptions. And they're just over 2 times more likely to die of potentially avoidable causes. It's also important to put that in the context of an overall understanding of poverty data. And this is not data that the Australian government spends a lot of energy reporting. And so the Australian Council of Social Service Organisations, ACOS, works with the University of New South Wales to analyse this data on a regular basis, and in fact produce this report that I'm referring to tonight last year as part of their campaign to see a permanent raise in income support, the Raise the Rate campaign. What their data, which is analysed across 2017-19, showed is that the poverty line, which is 50% of median income before household costs, for a single adult is $457 a week. And at the moment, or in that period, about 1 in 8 people live below that poverty line after accounting for costs of things like housing. And critically, it's 1 in 6 children that live below the poverty line. And we all know that, particularly in the area of chronic disease, but also in school attainment, all of those things link to being able to live above the poverty line. The average poverty gap, which is the gap between that median income and actual dollars going into a household, is $282 a week, which is pretty large. And poverty in Australia is just above the OECD average. And it makes us, amongst the wealthy group of nations in the OECD, one of the countries that has the highest level of average poverty. Social security payments, or affectionately known as JobSeeker now, used to be New Start, sits below the poverty line even after accounting for supplements for rent and energy. The youth allowance is $168 a week below the poverty line, and that's potentially less critical when you have youth that are supported by families who might be supplying accommodation. But when you consider homeless youth who are trying to educate themselves, it's pretty drastic. New Start, or JobSeeker, is $117 a week below the poverty line. And the age pension, which has been indexed now against the overall rate of inflation, is only $10 per week below the poverty line. Still below the poverty line, but you can see the criticality of indexing these payments. I think what's less known is that around 45% of all recipients of JobSeeker payments have exemptions for employment. And that means, and that's around 45% of about 800,000 recipients of JobSeeker. And those exemptions relate to either being the primary carer of children under the age of 5 or preschool, having a disability but not yet being resourced through the National Disability Insurance Scheme, or having an illness for which you now require support payments. And so part of the real problem for us is that the narratives on social security payments are always negative. And you will have noted our Prime Minister in arguing for the increase in JobSeeker through the beginning of the pandemic was because these people were unemployed through no fault of their own. And the idea that we have people previous to the pandemic actually being somehow responsible for their situation denies the reality of poverty in Australia. Health literacy is another really important contextual factor, and I'm not going to go through all of this, but suffice to say that the ABS Health Literacy Survey shows that the vast majority, in excess of 90% of people, think they've got good health literacy. But importantly, 2 in 5 people, only 2 in 5 people, so only 39%, think that it's easy to understand health information well enough to know really how to self-manage, and that about 54% say they usually find it easy if they're dealing with conditions that are not stretching them. So we find many people coming into a health system, particularly people from low socio-demographic groups who have low health literacy, who really will struggle with access issues to health. And people with low health literacy are more likely to have worse health outcomes overall and adverse health behaviours. And these include things like low engagement with health services, so less likely to participate in things like cancer screening, higher readmission rates to hospital, poorer understanding of medication instructions and therefore compliance with medications is poorer, and a lower ability to engage in self-care. So what then do those factors bring together in terms of their impact on cancer outcomes? So I've been particularly interested over the last decade in this issue that cancer outcomes are not equally good across our population. And it's often defined that it's much more about risk factors. So we know that smoking, for example, is much higher in lower socioeconomic groups, and that outcomes for lung cancer associated with smoking are overall poorer. But this data that I'm about to show you from the AHW is really put out about every 5 years, because it has to be grouped up to do socioeconomic analysis. And it kind of goes out into the public domain, and no one really ever says this is appalling. And part of my role at Cancer Council was really trying to draw attention to this, even though it wasn't necessarily a popular conversation. So this is the data from AHW for 2010 to 2014, which is the most recent reporting period. And just to give you an orientation, 1 is the lowest socioeconomic group, 5 is the most advantaged or the highest socioeconomic group. And overall, people in the lowest socioeconomic group are about 5% more likely to be diagnosed with cancer. And this needs to be put in the context that cancer is a disease of ageing, and people in the lower socioeconomic group also have a poorer life expectancy. And so if people in the lower socioeconomic group had the same life expectancy as people in the higher socioeconomic group, you would expect to see that gap wider. And there are a couple of cancers here I just want you to note. So overall, about 4, so prostate, breast, melanoma, and non-Hodgkin's lymphoma are cancers where people in the lower socioeconomic groups are less likely to be diagnosed. That's probably related to things like lower participation in PSA testing for prostate cancer, and in something like melanoma. Melanoma is particularly related to leisure time exposure to the sun rather than incidental exposure to the sun, which causes non-melanoma skin cancers. And so that is probably explainable about that lower incidence. And then if you look at something like lung cancer, obviously we've talked about, but something like cervical cancer, 52% more likely to be diagnosed with cervical cancer. So this is invasive cervical cancer. So, and these are not women in these age groups that will have been screened, had immunisation. So it's much more likely to be related to lower participation in cervical screening. When you then look at that by deaths though, when you look at all cancers combined, people in the lowest socioeconomic group are 37% more likely to die of their cancer than people in the highest socioeconomic group. And even for those cancers that had lower incidence, like prostate, breast, melanoma, and non-Hodgkin's lymphoma, even when they get them, they're more likely to die. So that overall gap is wider than you would expect it to be. And then you take something like head and neck cancer, where you're looking at 112% more likely to die, and cervical cancer, 136% more likely to die, about 220% when you talk about First Nations people. And these really are very poor indicators. Australia is about to become probably the first country in the world to effectively eliminate cervical cancer as a public health priority. And yet that will not be the case for our First Nations communities. Just to look at that in a slightly different way, I had the privilege of working with a postdoc called Hannah Tuvonen, who undertook an analysis of hazard of cancer death by socioeconomic quintile of disadvantage over time using New South Wales Cancer Registry data. And this is a unique data set because it includes summary stage. So in this data set, we were able to control for a range of factors that are often assumed to be why people in lower socioeconomic groups die from their cancer more often. And that's because they're more likely to be diagnosed with poorer survival cancer, so controlling the cancer site's important, or more likely to have advanced disease at diagnosis, so summary stage is important. And what you can see from this data is there is the gradient we've talked about towards a higher hazard of death for lower socioeconomic groups. But critically, that gap is widening over time, not closing. So as we see greater levels of improvement at one end of the spectrum for the higher socioeconomic groups, we're seeing the lower socioeconomic groups getting further and further behind over time, which is kind of a national tragedy and shame, and belies the rhetoric around our truly fantastic cancer outcomes overall. And when you look at that, and different researchers use different kind of ways of looking at this, but David Whiteman from the Queensland Institute for Medical Research, QIMR, did an analysis for us that suggested if you pulled the cancers for a 4-year period, and if everyone had the outcomes of the most advantaged group, you would see a 13% lower rate of cancer overall. And you can see again that is across a whole range of cancer types, not just lung cancer. And so we currently cure more than 5-year survival, about 70% of people diagnosed with cancer. You could potentially raise that up to more like getting closer to 80% just by getting rid of socioeconomic disadvantage. So we at the Cancer Council were also interested in what interventions work. And so led by one of our research team, Annie Bygraves, we undertook a systematic review of interventions looking at addressing socioeconomic inequalities in cancer and in high-income countries. And there were 16 studies that were reporting 19 interventions, and only 7 of those interventions reduced socioeconomic inequalities, and all of those were in screening programs. And you can see the sorts of interventions that were there, so really around reminders and endorsement to screen. But there was limited to no evidence for reducing inequalities in any other context. And this idea that it's only in screening that we can be active is really why I think it's time for nurses to step up to the plate on this issue and join our social work colleagues in really putting a focus on social disadvantage as a major factor in health outcomes. So if we go back to Maria now, Maria has been diagnosed with cancer of the cervix. And as you've already heard, she's more likely to get this cancer because she probably has not been participating in cervical screening. She can, when she's been working, she's not on a healthcare card, so she doesn't get the advantage of bulk billing at her GP, and she hasn't got a GP practice close to her that bulk bills. And she's now 136% more likely to die than you or I from this cancer. And in the context of her girls, that's obviously a worrying statistic. She's going to require about 6 weeks of radiotherapy, which will be at least 5 days a week trip to a cancer centre, and her nearest public cancer centre with radiotherapy facilities 40 minutes away by train, and she doesn't have a car. And all of those factors mean that it's about 4 hours a day to do her treatment, and she's really unable to work, not just because of the overall health effects of her radiotherapy and initial surgery, but just the amount of time that's being taken out. She is eligible for job seeker payments, but she's now effectively, that moves her family from just above the poverty line to below the poverty line. And that's in the context of having increased costs associated with travel, medications and appointments. So her situation and that gap for her will be very wide. We've also at Cancer Council looked at this, at the issue of both out-of-pocket costs and also financial burden, and Annie also led this work. And we found 19 Australian studies that looked at more than 70,000 Australians affected by cancer. And the overall out-of-pocket costs, so the things that you pay to your doctor, range from about 977 for breast cancer through to 11,000 for prostate cancer. And we can talk ad infinitum about what robotic surgery in the private sector has done to costs of prostate cancer treatment. But out-of-pocket costs, importantly, were not the only drivers, and indeed weren't the main driver for financial burden in those who are most disadvantaged. So if you look at who experiences higher out-of-pocket costs or financial burden or both in this analysis, so if you're under the age of 65 years, you're much more likely to experience financial burden, and that's because you're in your prime working years. And if you have to reduce your time at work, then that's going to have a bigger impact. If you're Aboriginal and Torres Strait Islander, rural or remote dwelling, or from low household incomes or unemployed. So those factors associated with poverty and particularly financial disadvantage were the profound drivers of financial burden. And then higher out-of-pocket costs occur for those who have private health insurance. But the difference there is that many people who've got private health insurance can absorb the financial burden, but not all can. And to really work with that, we've been developed at Cancer Council a standard for informed financial consent, because many times these out-of-pocket costs are a surprise to patients. So how might nurses make a difference in this context? What I've been talking about today really is situated at the macro level, and it's important that nurses understand that macro context, but nurses tend to work more at the micro level, and so that's what we'll spend some time looking at now. I think that we need some new lenses through which to look at nursing work. Some of them are new, some of them are old, but we need to take off whatever it is that we're looking at our practice through now and just shift the vision a little bit. I think nurses are often very focused, and quite rightly so, on the individual that's in front of them, when in fact maybe don't have a vision more broadly than that at a population level, which is why that balancing of macro and micro views is really important. So McFarlane and McDonald in the UK have talked about the role of nurses in addressing health inequalities following the Marmot review around health inequalities in 2010. So Michael Marmot has written a lot about the poverty gap, both within countries like the UK, but also globally. And he recognised that this increase is a major health concern, and that it is central to the role of nurses in promoting health and recovery and supporting health protection and providing health-related education. But McFarlane and McDonald say that nurses encounter the consequences of social and economic inequalities daily and see the effect that these have on the health of individuals that they care for, but they may not actually have the tools or the structures or even the understanding to really think about how that should impact on their practice. And they argue that nurses have a responsibility to identify and address the root causes of suboptimal health, which a major one, I'm arguing, are health inequalities or social disadvantage, and to be able to do that from individual or population or both perspectives to address the issues and prevent any further deterioration. A colleague of theirs, Mabala in the UK, has also argued that in thinking about how we frame this for nursing, that it's important that we see social justice and inequalities in health from three major perspectives. The first of those is scientific, and that's about the association between disease and the social environment. I've been kind of interested in and been trying to stimulate some of the laboratory researchers at Peter Mac to get some interest in this, because I saw a presentation a few years ago by Elizabeth Blackburn, who holds a Nobel Prize for her work on telomeres, the little caps on the end of DNA strands. And what she has published is the reality that people who have lower educational attainment have shorter telomeres, and the shorter your telomeres, the more likely you are to suffer from chronic illness. And for me, educational attainment is intimately linked up with ideas around social disadvantage. And it also begs the question of whether or not, because shortened telomeres tend to run in families, so the potential of inheriting a shortened telomere environment means that things like chronic disease may indeed be intergenerationally predisposed, and really brings about the importance of getting those children out of poverty. We also need to look at health inequalities from an ethical and moral standpoint. And I think that this is key to the heart of where nursing kind of began its journey. And the second head of the School of Nursing here at the University of Melbourne was Professor Siobhan Nelson, who's now in Toronto, who's looked a lot at the history of nursing and the ethical and moral foundations, particularly those that have come from the church. But this gives us an understanding that socially produced diseases and poorer health outcomes are preventable and avoidable, and are therefore unjust and unfair, and provides us with if you like, a mandate to say that tackling them is simply the right thing to do, and is at the heart of where nursing and indeed social work have had their origins and roots. And then the third lens is really to be able to think about this from a human rights perspective, and based on the Alma Ata Declaration of seeing health as a human right. And the aim around this perspective is to shift concern about the health of disadvantaged populations away from the charity sector, so groups like the ones that belong to the Australian Council on Social Service Organisations, into the realm of law and entitlement. And there have been some great examples of this within low-income countries. So the City Cancer Challenge Foundation that I have the privilege to be the chair of is involved in developing city-wide initiatives in low-income countries to bring together multiple stakeholders to really create cancer solutions in their local environment. But in Paraguay, one of the main outcomes of that has been the creation of a law enshrining if you like, universal health coverage to a certain level for the treatment of cancer for the whole population. And Mexico had done a similar thing some years ago. And so seeing these perspectives from a legal or regulatory environment is really important, and creates an opportunity, I think, for nurses and other health professionals to think how they might engage with people like those in the law. And one of the other great privileges of my time at Cancer Council has been to sit on the advisory board for the Centre for the Law and Cancer at Cancer Council Victoria, which really arose out of the Nola McCabe case against British American Tobacco for her addiction to tobacco from about the age of 12, that was ultimately settled after her death. But they now do a lot of work in the area of human rights and things like universal health coverage. So part of the challenge for us as nurses is that our confidence to ask about factors relating to social determinants of health is potentially low. Now, this is an American study of about 600 nurses, and they were more likely to feel comfortable about discussing issues related to access to care. So have you got a GP? Are you finding your way through to services within the hospital? But less than 50% felt confident to ask about things like transport, health literacy. Are you understanding the information we're giving you? Have you got sufficient social support to look after Maria's children, for example, during her cancer treatment? And the likelihood of asking about being extremely likely to ask was as low as 37% about things like housing. And we know that housing security, particularly for women, single women on income support over the age of 60, is really a massive problem. But we're not confident, less than half of us are confident in asking about these issues. And we're not at all, or only slightly likely to ask about things like income. The experience of discrimination was particularly relevant to people with disabilities or people from First Nations communities, the capacity to pay for utilities, access to food, with food insecurity being one of the biggest growing problems in the Australian context. And some of the barriers that Phillips identified were that nurses were saying this just took too much time, which is tragic and speaks to what gets prioritised in clinical environments. There were perceptions that the patients would be uncomfortable or experience discomfort if these questions were asked about in practice. There was personal discomfort about asking, and people had a barrier that they didn't really know how to approach these topics. And so really critical experiences. So what is it that we can do at that micro level to start to work with individual patients? And then what can we do to start to change the conversation? So I think the first responsibility, given this is a talk at the university, is to really appeal to educators to do a re-evaluation of the curriculum. To what extent are social determinants of health built into the curriculum and into the scenario planning for the case studies that are looked at across that socioeconomic divide? Do we tend to be drawn to cases that are more like us, higher socioeconomic group, or do we deliberately find case studies that really pull out these issues of social disadvantage? What are we doing about skills-based communication? So we do a lot on communication skills, but do we do that to the level of low health literacy that is required? And how good are we at doing that? Does our patient assessment and clinical assessments take account of factors that might be linked? Do we even ask if people fill their prescription, for example? Do we follow those things up? And how does that influence our care planning? Do we partner with schools with expertise in disadvantage and population health? And I'm really excited about the new venture between the Department of Nursing and the School of Population Health around a combined master's degree that I would encourage anyone in the audience who's thinking about a new master's to really consider that one. I think my biggest regret in life is that I didn't study epidemiology because I'm obsessed by population level thinking. Do we ensure that disease-based teaching includes an analysis of outcome variation across the population? Because when you don't look at outcome variation, you actually don't see the difference. And do we consider the clinical experiences of our graduates or our students from the perspective of inequalities? Do we expose them sufficiently to the experiences of this large group of people within our community who have much poorer health outcomes? What do we do then from a practice perspective? So I particularly want to draw your attention here to a statement or a law, an inverse care law that was first put forward by Julian Tudor Hart, who was a physician in the UK. And he said this in 1971, that the availability of good medical care tends to vary inversely with the need for it in the population that you serve. And that comes back to those, it's kind of what those boxes of people standing on them before was really representing. But I think it becomes a really important mantra when you think about what you do in practice. And I would appeal to all the clinicians out there to, in particular, to understand the population of patients you serve and compare that to who you actually see. And the reason, I've got two examples. One was an evaluation we did when I first started at Peter Mac in the early 2000s of the breast nurse database, which followed a really structured model of care that had been developed by the National Breast Cancer Centre across about a 12-week program. And the nurses were doing a fabulous job, and we did an analysis of that work. But what we found was that they saw about 120 patients with breast cancer a year. And when we looked at the hospital data, Peter Mac saw 5,000 women with breast cancer a year, but the vast majority came through either the radiotherapy or the medical oncology pathway and never, ever saw a breast care nurse. And yet they were more likely to be the people who had disease that was more likely to progress because they were being sent to a tertiary centre for their adjuvant follow-up treatment. The second example was at Cancer Council. We did an analysis by socio-demographic disadvantage based on postcode of residence, which is an imperfect measure in the extreme, but it's the best we have in most situations. And what we found was that you were 3 times, in fact, more likely to ring 13 11 20 cancer helpline if you lived in the most advantaged socio-demographic group than in the least. And so our services were basically being given to people who were going to have great outcomes anyway. It's not that they don't have high needs, but they knew more about how to do that. Is that a health literacy issue? Is it an availability? Do people in lower socioeconomic groups have less leisure time and less ability to ring in the hours that services provided? What sort of factors drive that difference? But it's a massive difference. I think it's really important to keep vulnerability top of mind in clinical assessment. And I'm really interested in actually developing a vulnerability index around how you might do that. But to begin with, you would be looking for anyone who's on income support. You would be looking for anyone who has a disability, who's got low educational attainment, and being able to ask questions, particularly about things like what brackets of income, whether incomes had to stop or change as a result of being ill, all help to keep vulnerability at top of mind. I think it's also really important to seek to understand the experiences of your most vulnerable patients. Like any human beings, we tend to be drawn to the people who are most like us. And unfortunately, because we tend to be people who live and work from a higher socioeconomic group, we actually tend to identify less with the experiences of the most vulnerable patients. And that's a really critical lens that we need to be able to develop. So we need to be able to seek out and talk to people about their experiences and really use that to understand how a practice should be developed. And then I think you have to use that information to rethink the models of care that you deliver. And I remember a couple of decades ago when we used to run a Living with Cancer program at Peter Mac, and it was run over about 8 sessions. It took a full-time nurse to deliver and a whole lot of guest lectures. And when we did an evaluation of it, we found that only about 3% of people who were going through the hospital ever considered it. And we used to have only, I think it was about, I'll have to ask Annabelle about it, but it was about 30 people who actually did the course in a year against about 5,000 people who came through the hospital. And so you actually think differently about how you deliver care when you think about who's accessing and how's it reaching. And the previous director of the International Agency for Research on Cancer says that any intervention that you develop, any model of care that you develop, should be evaluated for whether it narrows or widens equity gaps. And so I think that that's a really important thing to consider when you're developing models of care in practice. And I think it's really critical that we embed collaboration with specific health workers that have much more knowledge about disadvantage than we do. So social workers, absolutely top of mind, Aboriginal and Torres Strait Islander health workers, and now some of the new disability health workers that are coming into the system will be really important collaboration points for nursing. And it's actually not about the collaboration, it's about its embeddedness. How do you routinise that engagement without thinking that those workers have to fix everything? Because I remember talking to Aboriginal health workers about the fact that they just can't simply see everyone, or be primary carers for each of those individuals, but they need to be able to influence how we work alongside them. And then finally, we need to define quality care, develop indicators and measure it using an equity lens. And then finally, my last point really tonight is to say that for researchers, we need to incorporate social determinants of health into our research. There is no research that looks at this really from a nursing perspective. We need to use strategies to ensure our sample represents the population and includes groups with more disadvantage. Use an equity lens when you analyse your research and partner up with people who know more about this than nurses do. And finally, there's advocacy as well. So make sure you're getting your voice heard and use any opportunity that you have at any seat, at any table to make sure that disadvantage is part of the conversation. So in answer to the question I posed in the title, do nurses have the power to make a difference? They do. They can change the story, but we now need the research to prove it. And so for the researchers in the room, I'll put out a challenge to you. Thank you very much.
Oh, thank you, Sanchia, for a very interesting presentation. Now, we have a couple of questions in the chat, but I encourage others to put forward questions. The first one, though, comes from Kathleen Corliss, and she's asking a question about the hospital context, really, saying it's really interesting in regards to asking questions about health inequities and inequalities and about disadvantage, but whose job is it in the hospital environment to do that work? And I think that speaks to the heart of, you know, role clarity and interprofessional practice. But interested in your comments there, Sanchia.
Yeah, so I think, you know, the best example we've got of that is collection of Indigenous status in recording it. It's really poorly recorded, and so that would be one of the indicators that you'd want to see, and that's obviously a question that's asked at intake. But I believe that nurses working in collaboration with their medical colleagues, certainly from a cancer perspective, have a role in this area. Admitted patients, it's easier. The inpatient nurse is in a better place. But given that most people come through an outpatient clinic, what are we doing as routine nursing assessments for people coming through ambulatory services and I don't think we need a lot of questions. I think we just need a couple that alert us to this particular issue, because what you'll find, and I haven't used the story of my niece in this talk tonight, but I'll bring it in here. My niece was a registered nurse at in the psych unit at St Vincent's. She had a lesion on her adrenal gland, and she was actually carrying a lot of debt out of her first marriage. And so when she needed a referral, went to a public clinic. She waited 6 months for that clinic appointment because there was no assessment either of her vulnerability to having cancer. So cancer is a disease of first exclusion, but actually she couldn't afford to go to a private provider. She talked to me a bit more at the time. I might have paid for it for her, but I think we need to recognise that these things actually change outcomes. She went from having a highly curable disease to not. And so if we're not asking at intake, so there's a point at intake, and then there's a point when at that first clinic appointment where these things really just need to be canvassed. And we need to be advocating for the resourcing of outpatient clinics to actually take account of that, because at the moment they're not. The nurses in our outpatients often have very underdeveloped roles, whereas they could make a huge difference if we put more clerical staff to do a lot of the non-clinical things and more nurses actually doing these sort of intake assessments.
Yeah, of course. And I think housing status is the other one, Sanchia, of course. For many years I worked in an emergency department and that data was really, really poor. But we know that, you know, just categorising people as homeless or not doesn't really capture it, that there's a whole lot of qualitative information about what's recorded and how that's understood in terms of people's ability to manage their own health and access just basic care, really basic.
That's right. I mean, if you look at some of the things that are happening around even bed, the way young people are living in community where they've actually got shifts in beds, you know, the ability to lose that opportunity, just lose any home. But you could ask a question, does becoming ill threaten your ability to keep your home or put food on your table? You don't have to ask them in really detailed ways. You can ask them in quite high level ways.
And it's interesting the comments that you made about communication. During the COVID-19 pandemic, we were working with the School of Population and Global Health. We were lucky to be part of a group developing a Communicating COVID course. And a lot of it was focused on how to frame questions and how to make those things easily understood and checked out. And it is true that the COVID-19 pandemic has probably widened the gap for a lot of people, right?
Yeah, I know it absolutely will have widened, and I think that'll be one of the really interesting things to look at in the data as it comes through. But the problem is it's going to take so much longer. But certainly things like housing and food insecurity. one of the women that we interviewed a number of people when we were doing the financial consent work, and also looking at supporting the ACOSH Raise the Rate campaign. And we talked to a patient from Western Sydney about what had happened as a result of the increased payments around job seeker after the pandemic allowance was put in. She said, I went from feeding my family once a day to twice a day. And the patients will not tell us that. They are embarrassed. Unless we actually ask the questions, we will not know the answers. And we won't be able to impact. If you have to choose between feeding your family twice a day versus filling your prescription, you're going to feed your family.
Yeah, absolutely. One last question before we wrap up, Sanchia. Well, it's a comment and it comes from Jeanette Cameron, and she's asking about posing the question, have we lost our way with this? If we believe that we provide patient-centred care, what are we doing? How do these concepts relate to patient-centeredness?
Yeah, so I actually think we have lost our way a bit, although I'd have to say that I even, right back, I don't think we had issues to do with social and determinants of health embedded sufficiently in the curriculum. But I think we did more of it in practice. We had more time with our patients. People were in hospital for longer. You actually got to know them and their family circumstances more. And I think we've had this important shift in nursing towards a greater science basis and a more focus on really the sort of structured intervention to manage things like symptoms and other things. But it's really important that we don't swing that pendulum too far, and that we recognise that nurses actually have the capability of improving survival from diseases like cancer through the work that they do and the awareness around these things and it does go, as Siobhan would say, right back to the heart of where nursing began, because it really began with the poorest of people, and so maybe it's a bit of a shift back in that emphasis.
Absolutely. Well, Sanchia, thank you so much for your presentation. The Marian Barrett lecture has been a fantastic way to stimulate conversation. I think it's just the beginning. The points that you raised and the directions that you've given in relation to clinical practice, education and research are really inspiring and food for thought, certainly for me and for everybody here at Nursing at Melbourne. So we really hope that people will start a conversation about this and move it into the practice, the education and the research domains where this work belongs. And it's just the beginning really of thinking about this and taking definitive action.
Thanks.
So that concludes our Marian Barrett lecture for 2021, but I do want to draw people's attention to the 25 Years of Nursing seminar series, of which this is the second presentation. Our next presentation is on Thursday, the 12th of August, same time, between 6 and 7 p.m. The title there is, What are the implications of voluntary assisted dying for the nursing practice? This will be a panel discussion, so slightly different format to tonight. The discussion will be hosted by none other than our Honorary Professor Peter Hudson from the Victorian Centre of Palliative Care. Please be sure to tweet this and other communications about 25 Years of Nursing at Melbourne via our Twitter hashtag. And thank you once again. We look forward to seeing you again very soon. Don't forget to fill in the survey at the end of this session. Goodbye.